Hi, everyone. Thanks for joining us. You know, physically, mentally, emotionally, spiritually, we're all living through a very, very difficult time, kind of in the middle, not kind of, but in the middle of a health crisis. And it's a tough go for all of us. On this edition of This is America and the World, we're going to talk a little bit about telemedicine, which has been pushed into the forefront during the pandemic. And then a little later on, we're going to talk about depression and suicide, and specifically the warning signs that someone might be experiencing that would be pushing them or driving them towards suicide. And we're thrilled to be able to talk with Dr. Jay Shore. He's an MD, psychiatrist, and he's with the Department of Psychiatry at the University of Colorado. So, Doctor, good to visit with you today. Thank you so much for joining us.
Thanks for having me on. I appreciate it.
When you look at the pandemic, what do you see?
As you said, I think we're all living through unprecedented times, not only for our healthcare system, our behavioral healthcare system, but really for our society. And then as we live through it, I think every one of us is trying to adapt in the very dynamic environment with things that are changing daily that in some ways are unbelievable for what we've experienced previously.
Thank you, Doctor. Telemedicine, this idea of video conferencing. Talk a little bit, you've been a pioneer in this area right from the get-go. And then the pandemic comes along and pushes it forward. Where are we with this idea of telemedicine? And then we'll move on to telepsychiatry and talk therapy.
Well, I'd like to say I've been there from the get-go, but video conferencing to treat patients, one of the first services was in 1959 at the University of Nebraska. So the concept of using video conferencing and doing this work was around for a long time, but it didn't really become very feasible until the 1990s with the cheapening of technology. And then the last decade with these more portable web-based video conferencing platforms set off a second wave of diffusion. And so what was really interesting when I first got into this is we just tried to replicate what we did in person over the video. Then over the last decade with more ubiquitous video conferencing and more tools and other things like electronic health records, patient portals, it allowed us not to just replicate what we did in person, but change how we provide care, to provide care closer to the patient, in the patient's home, in some ways bring back the virtual, we've changed it to the virtual house call. And now during the pandemic, we weren't doing those things before that. And so what I really enjoyed the last decade in this field has been really how it's beginning to shift how we can deliver care and the models of care we want to do in the field of mental health. And then, of course, in some ways, for behavioral health, I really do think that the pandemic is a game changer in how these systems functions, how we interact with patients, because of the need to use video conferencing as a way to support social distancing and safety. And, you know, I would say before the pandemic, telepsychiatry, telemental health was widespread but sporadic. So some institutions were doing some of it, maybe a lot of it in some places, some zero. You know, after March, every behavioral health provider organization is doing some kind of remote care technology right now. And so it was a game changer.
We're going to take a little break right now, Dr. Shore. On the other side, I want to ask you how effective it is for the patient and for the client and for the professional healthcare provider, specifically with this idea of talk therapy. So take a little break. Back on the other side. This is America and the World. Underwriting for This Is America and the World is made possible by the National Association for Children of Addiction, Faces and Voices of Recovery, the Forerunner Foundation, the Rotondaro Family Trust, the Sultanate of Oman, the Kingdom of Morocco, and the Embassy Series, Uniting People Through Musical Diplomacy. Dr. Shore, all the way from the University of Colorado, thank you for educating us. I know a few therapists, and I know a few people who are doing therapy by way of a Zoom call or something like that. How effective is it to do something that's very, very sensitive in a Zoom call?
So the simple answer, based both on 20 or 30 years of randomized controlled trials and my clinical experience, it is as effective if you look at outcomes as doing it in person. And that's what the scientific literature supports and what our experience supports. The more nuanced answer is, I see it as a tool, and every tool has its strengths and weaknesses. So when I see a patient in person, there are many strengths to that, but there can be some drawbacks. And the same thing with video conferencing. Let me give you an example. In my career, when I first started doing this, one of the things I do is provide treatment up in Alaska, and I was working with Alaska Native women who'd been traumatized at the hands of men. And as my wife says, I'm sort of an outdoor toy. I'm 6'5", I'm large, and I speak loudly. That's just who I am. So a woman meeting with me for the first time who's struggled with domestic violence may not feel as comfortable. So I was doing these video sessions, and these women from different cultures who I'd not met in person were telling me, wow, Dr. Shore, I was able to say things and share with you in the first session I've never been able to share with anyone before. And when I would ask at the end of the session why they thought that was, it became clear to me it was because we were working over video conferencing and I was 3,000 miles away. They had a sense of safety and control and space over the interaction, which would have been different had I been in the room with them. So for that patient population, I may have better outcomes seeing them over video. There may be other patient populations where it's a bit more work. I have to modify my style and do things a little differently to get as good an outcome. And then faced with the choice, I may say, I want to start with this patient in person. So it's about really that concept of personalized medicine, understanding the technology and understanding how to adapt it to a patient. And I think circling back to one thing we said about COVID is in the field of telemental health, we have this concept of hybrid relationships between patients and providers. And that means you're holding the relationship with a patient through multiple mediums, in person, over video, through a patient portal, through the phone, through the text. And so you don't have a relationship just in a room with a patient, but over this virtual space. And I think we're moving to hybrid relationships in mental health, emerging from the pandemic. I think we'll see more hybrid relationships. That's where all our relationships are now in our personal lives right now with this pandemic too, right? We're all in this sort of hybrid world between virtual and in person. And that's where I think medicine is moving.
But here's I want to put this to you. Our life, as you have just said, is one big Zoom meeting. I mean, it's Zoom, it's FaceTime, it goes against the grain of being a human being, which is social contact. All of our social contact is now on a screen. You and I both. I mean, my preference would be that you would be sitting on the other side of the table. Are we going through a period of time of just fatigue as far as screen time is concerned, especially with kids?
Certainly. And this is, you know, wasn't really mentioned prior to COVID in terms of the medical literature. I have providers I work with who do 40 hours a week of seeing patients over video, and rarely had this come up. But as soon as the pandemic hit, there's a lot of articles on Zoom fatigue, but it's really video conferencing fatigue across any platform. And I think it is complicated. One, obviously, when you're living your whole life in virtual and there isn't a balance, that contributes to it. Secondly, we're all under tremendous stress, sitting in a quarantine, we're not being able to get out and have those other interactions. And third, I think in the business place and in medicine, those of us who are Zooming, in some ways, Zoom and video conferencing is very efficient. So when I have 8 hours of back-to-back Zoom, there doesn't feel like there's a break, as opposed to when I used to have a day where I had 3 hours of a Zoom, a conference call, and 3 hours of in-person. Even those small breaks of getting up, walking to another building, seeing someone and having a non-business conversation, the water cooler talk in the hall, about a TV show, or just checking in person, it's a different level of energy. And so I certainly think it is real. It's complicated. I think it certainly has a greater impact on children in development who obviously need some of that blend of social context. So I certainly recommend, I'm excited about the power of video conferencing to increase access, but hybrid relationships mean just that. It doesn't mean all virtual all the time either. And that's where some of us are.
I was talking with someone the other day, and we got into a discussion about introverts and extroverts and how either was handling the pandemic. Well, you're laughing. And also, I was talking with a friend of mine last night who is obviously much more gregarious than I certainly am. And he was missing. I mean, the working at home, is just a chore for him. I mean, he just wants to have that water cooler conversation. Introverts, extroverts, and you were laughing right as I asked the question.
Because my household, I'm married with 2 daughters, and we're split 50-50 in my family. Myself and my older daughter is an extrovert, and my wife and younger daughter are introverts. And it is interesting. I think everyone's been affected by the isolation and the pandemic, but it is harder. And some of those days where I'm sort of, let's go bike to somebody's backyard and go social distance at 10 feet or something like that. And the introvert side of the household, they seem to be doing a little bit better. I think they're stressed by the pandemic, but it is sort of a different approach. And I think that in some ways that framing does help to some extent introverts manage it maybe a little better, but at some point you just have this accumulation of, we're all social beings, whether we're introvert and extrovert. And this is not, there really has never been a time, I guess, during past plagues, we could be thankful that I guess we could be in medieval Europe during the Black Plague and stuck in a house for 6 months without any of the virtual contact. But this is a very rare condition for human beings to be in like this.
Doctor, I want to shift gears with you and talk about your work at the Johnson Depression Center. I've never heard of a center. What's a working definition of depression?
So depression, there's sort of a lay definition, right? And then we have in psychiatry, in the medical field, a definition of depression where your mood is down for at least 2 weeks, where you're less engaged. And then there's a number Within that definition, we look at specific symptoms. Is it affecting your sleep, energy, and appetite? Is it affecting your sort of your body, whether your body's sort of sped up and slowed down? Are you having suicidal thoughts, thoughts of guilt? So we look across the spectrum. Are you having a period of at least 2 weeks? And do you have enough of these symptoms to meet criteria for what we would call a major depressive episode? I also, if you'll indulge me for a second, the Helen and Arthur E. Johnson Depression Center is part of the National Network of Depression Centers, established by a philanthropist, George Wiegers. And his idea, we're called the Depression Center because he wanted people, you know, to be able to talk about depression. We have all these cancer centers, right? And it's no big deal, right? We have cancer, you go to a cancer center, you get it taken care of. It was George's vision and idea to help to mainstream that concept of depression. It's a medical illness. It deserves a center. It is something that can be treated and addressed. And so that's why it is part of this this network of depression centers around the country.
Is there a kind of a, I don't know quite how to frame this, a progression of stress, anxiety into depression? Am I on the right track there?
It is. I mean, there are so many different sort of flavors of depression, so to speak. And so that is certainly one way to get to the point where you would get a diagnosis of major depression, starting out with sort of increasing stress, anxiety, and there's sort of anxiety, and there's anxiety disorders like generalized anxiety, panic disorder, and then there's depression with anxiety too, right? And so often, and typically, that a consequence of too much stress, certainly an inconsequence, can be symptoms of depression.
Is it a physiological, a biological diagnosis that we're talking about when we talk about depression?
It is. And I think that's hard for people to grasp, that the depression's a medical illness. There are measurable, identifiable biological and physical changes in your body when you begin experiencing the depression. It obviously has a psychological and behavioral component, but so do other medical disorders such as hypertension and diabetes as well. And so, it is this complex interface of psychological and physical, and in some ways, and we often have a false dichotomy between the two in Western medicine.
Is just as I went from anxiety, stress, anxiety, depression, is treatment, talk therapy, medication, possible hospitalization? Is that also a 1, 2, 3?
It's not, and again, that's sort of one pathway, but there's sort of many ways to get to Rome, so to speak.
Please.
And so, and with treatment too, there are evidence-based therapies that can be as equally effective as medication. And it really depends, that's why as a psychiatrist, when someone comes in, you do a thorough assessment looking at the biological, the psychological, and the social aspects of the patient's distress, and come up with a treatment plan and recommendations, which could be, hey, why don't we start with therapy? Or, no, this is going on, why don't we do a combination of meds and therapy? Or, right now, given what's going on, let's look at starting with medication. So it's really about taking sort of these bigger disease concepts, but really being able to tailor it to the distress that the patient in front of you is managing and dealing with.
When, as a family member, or as a friend, or as a coworker, do we say to family member, friend, coworker, you seem to be going through a bad patch? I'm here to help. Can you talk about that a little bit? When do you ask the question, Have you been thinking about suicide? Have you been thinking about particular means of suicide? When do you ask those questions of a family member, a friend, or a coworker?
As soon as you have a concern. There is
Say that again, please.
As soon as you have a concern. I think we all, in general, people err on the side of not asking. I think the two keys is when any of our friends, family, coworkers, and loved ones, you're much better off getting the answer that I'm actually doing okay, but thank you because you care about me, than missing something. And I think there's sometimes a myth that if you ask about it, and this is clearly a myth, that if you ask, and specifically about suicide, that you will give people ideas about that. Just absolutely not true. And so, one, you need to, if you really are concerned about someone's safety, ask, are you having thoughts about not wanting to live? And you need to also, I guess I would say, if you're prepared to ask the question, you got to be prepared to listen. It's one thing to say, I'm worried about you, you're distressed. Are you having some thoughts that life isn't worth living? Are you having some thoughts about suicide? Versus saying, you're not suicidal, are you? Right? I just asked that question so you could make me feel good and you wouldn't give me the answer because I don't know what to do with it, right? Mm-hmm. You need to be willing. One of the most powerful things we can do for other human beings is to be open to listening. And people can tell that, right? So when you're asking those questions, you need to be prepared to be there and listen.
And let me ask this, Dr. Shore, as we're kind of heading toward the finish line here, when should that person be asking that question of themselves?
It's not a question that they ask, am I suicidal? I think people begin to, and again, every pathway is a little different, but often you can see an escalation of distress. Suicide can often be a response to being overwhelmed and not feeling like there are many available coping options. The coping options, the different ways to handle things begin to narrow. And that can be a warning sign for all of us when we feel overwhelmed and there's just sort of no way out of a particular situation or circumstance. And that can be really, really hard to ask for help then and go talk when this begins to happen. We don't want to appear weak. We don't want to burden others. And I think it takes a lot of courage to acknowledge that we're human beings and at times we all need help, and sometimes you really have to dig deep to find that strength to begin to have that dialogue where you go to someone and say, look, things are beginning, I'm struggling here and I don't know what to do. I need some help. And that can be tough.
So the key is, or we can end on a note that it's okay to ask for help, huh?
It is. It's important to. I do it every day, all the time.
Terrific. What a wonderful conversation, and thank you so much, Dr. Shore. This is, I look so much forward. And I know, as you said at the beginning of the program, you're wearing many hats, and I would be remiss if I did not ask you in closing how your populations dealing with Native Americans, folks in Alaska, veterans, in a kind of a broad way, are they doing okay, or how are they doing?
I think sort of across the populations, I work with, the Leonard Cohen song that says, there's a break in everything, but that's where the light gets in. And so despite all the stressors we see in our society right now and the pressures, it's also so wonderful to see these communities and populations sort of rising to this and helping each other out. So sort of broadly, I think all of our communities are under different types of stressors. But what gives me still energy is just, which isn't making the news as much, is sort of the day-to-day heroism you see in all this behavior. I think the Plague by Camus, that book, right, was fundamentally about Heroism was about being a decent human being and doing the decent thing, not the best thing, but the decent thing when you're under this tremendous stress. And every day I see people being heroic in that and across these communities.
Dr. Short, thank you so much for the education. Terrific to be with you. Thank you.
Thank you so much for having me on. I greatly appreciate it.
Thanks, Doctor. If you are in crisis or know someone who is, these resources offer immediate help. For information about This Is America and the World, visit our website, thisisamerica.net, or our YouTube channel, This Is America TV, and follow us on Facebook and Twitter. Underwriting for This Is America and the World is made possible by the National Association for Children of Addiction, Faces and Voices of Recovery, the Forerunner Foundation, the Rotondaro Family Trust, the Sultanate of Oman, the Kingdom of Morocco, and the Embassy Series, Uniting People Through Musical Diplomacy.